Next presenter is Sushmita. She will be talking on surgery, particularly the ab interno angle surgery. Sushmita.
Thank you so much, Dr. Mandal sir. He's really been a beacon to all of us who are following in his footsteps in taking care of these babies. So, as we've heard, children are a different challenge completely. And it's not just the pressure, it's vision, and it's looking after them for a whole lifetime. Unfortunately, trabeculectomy will always be a ticking bomb, and tubes are really, really dangerous in small children. So, to avoid these bigger bombs, ab interno procedures would be desirable. The idea, of course, is to spare the conjunctiva, have minimal disruption of the conjunctiva, sclera, and iris. And the idea of the angle-based surgery is that they bypass the non-functional trabecular meshwork and have an outflow. It does not preclude further surgery, but at least for a start, and a lot of these children, just an angle surgery might be enough. So this is what a normal infantile angle would look like on gonioscopy. This is a type 1 angle where some trabecular meshwork is visible, but there are iris processes. And this is a type 2 angle where it's really, really highly inserted and the trabecular meshwork is not so well seen. So the type 2 angles really are the ones where you would bear in mind that possibly he would require something more than an angle surgery, but a type 1 angle is the one which is likely to work the best. So the prerequisite, as Dr. Debashish just told us, is a microscope and head position, rotation. So you need to rotate the microscope in one direction, you need to rotate the head in the other, and you gently place a direct gonio lens. Our personal favorite is the Swan Jacob, but any gonio lens is all right as long as you can see the angle on the other side. So you can see that's how the gonioscope is being placed, and the surgeon would be sitting on the opposite side of the eye being operated upon. So just surgeon's position, as you can see, that's one of our fellows operating. The microscope is tilted, the head is tilted to the other side, and the idea of tilting the head to the other side is getting the light straight into your eye here so that you can operate on the angle rather than look into the cornea. Goniotomy, we just slice the abnormal trabecular meshwork. We do as much as possible. Here we are using an MVR blade, but you can use a needle. Initially that is helpful because you can put it on a visco syringe, and in a moment you'll see the difference between the treated and the untreated angle. And this, you can see the iris which has fallen back, and here the rest of the angle being treated. So we treat as much as we can. And this is an Axenfeld-Rieger, and you can see the angle before and after. So that's the cleft which has been formed, and that's how the aqueous goes out. A bent angle needle goniectomy really is an extension of a goniotomy. The idea is to remove a strip of trabecular meshwork rather than just slice it. It's a low-cost Kaushik dual blade, if you were. But we actually did a small RCT, and we did one eye bang and one eye goniotomy, and we didn't find much of a difference. So we don't do the bang in children anymore. But in a minute you'll be able to see the strip. So here you are at the tip of this needle. What tissue you see is trabecular meshwork. So it's really a strip of trabecular meshwork which is stripped off. The trabectome is just using plasma energy instead of manually removing it. I don't think there's any great advantage in using a trabectome with its inherent cost, but then if you have it, that's something which you could think of doing. The gonioscopy-assisted transluminal trabeculotomy, or the GAT, has proved to be very, very interesting in children because you can treat 360 degrees at the same time, ab interno. We don't have the illuminated microcatheter in India as yet, so we use a Proline. You will soon see, look at this fluid wave. This is how much aqueous was dammed into the eye, and the minute you enter the eye, it all comes back. So you put in a little bit of pilocarpine, a little bit of visco, and you use a blunt-tipped Proline suture to enter the eye. You can see the harbs pretty well. So it is a reasonably hazy cornea, but if you can see the angle, it can be done well. The only problem is you need 2 ports, so you need to remember to suture both ports. So this is just going in. I'll go a little ahead. So you need a max grip forceps or any intraocular forceps to grasp the end of the Proline. and an incision has been made into the trabecular meshwork, a little goniotomy is done, and then this proline is just threaded through. And if it goes in smoothly, and you can see it in the trabecular meshwork, this blue thing, this you know that this is going into the angle. So you just keep pushing it in, and 360 degrees it will soon come out of the other side, and then you can hold it and strip it off. So 360 degrees you strip it off and you do it in one go. Another way to do it if you're not comfortable with GAT is to just do as much goniotomy as possible, do a nasal and then do a temporal by going to the other side. But this we found is easier. So here the end has been grasped, as you see, there you are. So that end is being grasped and the external one will be pulled out. So one end is here and there it is. And then you just hold the other one outside and you pull out the whole thing, and there you are. This 360 degree trabecular meshwork is sliced in one go. So how does angle surgery fit in? Quickly, some clinical situations. Sometimes we do it after a combined trab with trab. So glaucoma since birth, you can see left Peters anomaly, right PCG. We see these varying anterior segment dysgenesis often. But even though we've done the CTT in both eyes, the right is still very hazy. So the idea is, rather than going ahead, can we do a goniotomy of the rest of the angle? So we do that. We call it a secondary goniotomy because the rest of the angle is not treated as yet. So you can see the haze here, and actually some of them do quite well, and like you can see, this baby is really cleared. So we avoided a tube, we avoided a second surgery, we avoided needling, we avoided all that. We just went in and treated the rest of the angle as much as we could, and actually this cornea cleared and the IOP comes down. So we use a secondary goniotomy often. This publication came a couple of years ago. It's been very, very encouraging, so we've been pushing. And I was very happy to be sitting in a free paper session today, and there was a paper of 1 year results of goniotomy from somewhere else. So I was very happy with that, and it's encouraging that people have started doing goniotomy for children and are happy with the results. So how do we plan? Now this baby, for instance, clinically I think this should do well with the goniotomy, but this requires a little more because it's already ophthalmic and it's already hazy. But rather than doing a CTT, I decided to do a GAT. So this baby's got a GAT in one eye and a goniotomy in the other. And the beauty is, this is first post-op day and they're opening their eyes wide to look at you because you've done nothing to their conjunctiva. So that's what I love about this surgery. And you can see on day one how the cornea has cleared. He stayed well till about 2 years now, and you can actually see the ophthalmic eye has become a little towards the normal as well. But so far so good. He's stable, but we hope he remains that. There are some sad stories. Pediatric glaucoma will tug at your heart and make you feel worse than possibly their parents as well. This was a child, came to us at about 6 months of age. We did the combined CTT. He did well, followed him for about a year or so, and then he disappeared. He came back to us 3 years later. He didn't come back with COVID. He came to the emergency like this. So it's very heartbreaking. That's what I meant by saying a trabeculectomy in a child is a ticking time bomb. You have no idea what muck he's going to take into his eye. You have no idea how much he's going to rub it. But this is real time. This is every day. He already had a thickened sclera and he had a T sign behind. There was no way that we were going to save this eye, so it had to be eviscerated. And now he had uncontrolled glaucoma in the other eye. So it was so scary. I didn't know what to do with him. This huge eye, uncontrolled. So what we actually did was a GAT, thinking that let me treat as much of the rest of the angle, knowing that superiorly there is a combined trab with trab already. So at least you have the rest of the angle to treat. So you go that way. The only thing with surgeries is that you need to know which way to go. So this was the right eye. You need to do this much here. You need to treat that. So interestingly, you can see the proline suture which has come out through the former trabeculotomy. So that was so nice that at least the former trabeculotomy is working as well. And then, this was very, very interesting. So we were so happy to see that suture come out of the trabeculotomy. And now I was sure that now we just pulled out this whole thing, and we were sure that the 360 is working. And this boy has done very, very well. And I'm so happy I didn't have to go in with a tube or go in, because socioeconomically they're going to be the same, and I can't afford to have him come back with the other eye as well. Early days yet, but my preliminary thoughts would be children, if you can see the angle, even if hazy, yes. Whether you do goniotomy, bang, GAT, trabectome, whatever it is, just get rid of that dysgenetic trabecular meshwork. Ab interno techniques are expanding to include more and more trabecular meshwork and excise rather than incise. It's viable. It's safe, it's low cost, and it's worthwhile as a first procedure. I acknowledge all my residents who work day and night to let me make presentations like this, and thank you to my center. Thank you, sir, for having me.
Thank you, Sushmita, for giving the detailed description of surgery and excellent video.